right, well, good afternoon, good morning, everyone, and welcome to this important webinar on vaccine preventable diseases organized by the Infectious Disease Alliance. My name is Ellie Ongeber, and I am the Committee Manager for Vaccine Preventable Diseases with the IDA, and I'm honored to be your host today. We have an outstanding lineup of speakers who will share their experiences. First, Rodrigo Scottini will give an introduction to the Infectious Disease Alliance. Then Dr. Bolette Subort will discuss adult and infant immunization needs in the Danish life course vaccination models. Then Dr. Catherine Vieux-Olivier will provide insights into strategies for vaccinating older adult populations and overcoming those associated barriers. Then Dr. LJ Tan will highlight strategies for improving adult vaccination rates. And lastly, Sandra will speak on the role of community outreach programs in life course vaccination. After these keynote presentations, we will also have a question and answer session moderated by Dr. Norman Begg, our vaccine committee advisor, where you'll have the opportunity to engage with our experts in the field of vaccine preventable diseases. Each speaker has 10 minutes for their presentation. Anyone who has questions can write in the chat or raise their hand at the end during the Q&A session, and we will go from there. Thank you so much for joining us in this important conversation, and let's get started. So first, I'd like to welcome Rodrigo Scottini, our Executive Director, to say a few words about IDA and the importance of vaccination.
Thanks, Ella, for the introductions, your kind words, and funny we're matching jackets today. So I'm the Executive Director of the Infectious Disease Alliance, which is a global public health advocacy organization dedicated to addressing the most pressing issues in infectious diseases around the globe. So our alliance brings together a diverse group of stakeholders, including civil society mainly, but also in partnerships with public health institutions and researchers, as you can see in our panel today. We work for advocating for infectious disease policies and resources, aiming at preventing, diagnosing, and treating infectious diseases. So IDA is committed to tackle some of the world's most urgent and complex infectious disease challenges through a combination of health advocacy and cross-sector collaboration. We work to develop sustainable solutions that improve global health outcomes. Vaccination is one of the most pressing issues today, where significant gaps have been identified in general, and ultimately, with the current geopolitical situation, it's an area of more importance and needs of action. While childhood immunization programs are well established, adult vaccinations often remain under-prioritized, despite their potential to prevent illness, protect public health systems, and support economic stability. So today we'll have we'll hear from leading experts in the field as we explore challenges in immunization uptake, the role of healthcare systems and policymakers, and strategies to strengthen vaccines program across all age groups. Through this discussion, we aim to identify actionable solutions that promote equitable vaccine access and help overcome barriers such as misinformation, access limitation, and policy gaps. I'd like to quickly share here a presentation about our work. I will not take more than 5 minutes. So you have heard from me what IDA is and what we do, and I would like to say a couple words on what type of membership we have. So our mission is, of course, to unite civil society organizations working in infectious diseases, and we advocate for policies. We promote healthcare system strengthening, we promote access to medicines and vaccines. We offer for members access to critical tools, network opportunities for global alignment, for joint advocacy efforts, and opportunities for partnership building. We provide joint representation through civil society, unifying the fragmented groups, bringing accountability to policymakers, and promoting exchange between stakeholders and actors. Collaborative partnerships is a slogan for us. We really believe that working together is extremely important. As I said, our members are NGOs, professional societies, civil societies, patient societies, and research institutions. We do collaborate with other actors in the public sector. And our members, if there are any organizations here today that are interested in joining us, you can get representation of one of our committees, for example, the vaccine committee. You can participate to our events, update the alliance with our events, and get updates from other members. The committees we have are here as follow. Vaccines preventable diseases is one of them. There are some upcoming events. I would like to call the attention of this group here for the European Parliament event on the 10th of June in Brussels at the European Parliament, which would be tackling vaccine hesitancy. So if you are interested in this topic and are in Europe, please feel free to come. We'll try to disseminate this event, also broadcast this event as well. But for better interaction, of course, the event will be open for physical participation in the European Parliament. I believe some of our speakers here will be there as well. And we have also some other upcoming events, for example, WHA. If you're attending Geneva, please, you're attending WHA in Geneva, please feel free to reach out to us. And then you have the One Health Conference also in November, following the Danish presidency's priorities for the EU. So here are a list of webinars, including this here today on the 3rd of April. You can register for other webinars. And I will jump a bit about our team and our strategy to focus on one important project that we are running today, which is the Infectious Disease Policy Report series, with having volume 1 on vaccine preventable diseases. This will be a comprehensive report mainly on infectious disease policies. In this case, the first volume, infectious diseases, vaccine preventable diseases, which will be linked to an atlas showing what are the different policies, like existing policies in terms of requirements, in terms of coverage for childhood vaccination and adult vaccination. So I'll stop my presentation here, and please, everyone, get introduced in the chat so that we know who's around, also for interaction, so you should get to know each other, add each other on LinkedIn for future networking opportunities. So thanks, and back to Ella.
Great, thank you so much for that, Rodrigo. So there we go. Now to introduce our first speaker, Dr. Belette Soborg. She is the Deputy Director and Head of the Vaccine Preventable Disease Unit at the Statens Serum Institute here in Copenhagen, Denmark. And she will be discussing an overview of adult and infant immunization needs in the Danish context. So over to you, Dr. Soborg.
Thank you, Ella, and thank you for the kind invitation for this webinar. And as said, I just want to introduce the Vaccination Across Lifespan in a Danish context. And I have to disclose that vaccination in the sense of an adult vaccination program has not yet been established in Denmark, but is something that is under close discussion. But of course, we do have vaccinations for adults in, for instance, the seasonal programs. So can I have the next slide, Ella, please? So just to introduce myself just a little bit more in detail, I am a medical trained doctor, and I am also in member of our NITAG in Denmark, and I have been leading the vaccination programs, and now I'm leading the surveillance of the vaccination programs in Denmark. So I am on the more of the side of our of the ones that actually do the vaccine. What can you say? The vaccination program and so. We of course acknowledge that vaccination is one of the most cost-effective public health tools, and we do have a very well-established childhood immunization program in Denmark. But as I said in the beginning, the adult vaccination program is underutilized. We do have the seasonal vaccinations, but we do not look at vaccination program in Denmark as a life course vaccination. And we are aware that this could have a lot of advantages, but of course it's also very costly. And of course there are other opportunities. Of course you could pay part or some of the vaccines. So can I have the next one, Ella? So for us, if we look at close at Denmark, we do still lack a clear national strategy for an adult immunization or vaccination program. We do have influenza and also COVID vaccination. The pneumococcal disease, we did have vaccination program during the COVID pandemic, but it has been discontinued, and there is a process to look into whether to make a restart, but we do have to then look closely at which groups. When we look at the data for our influenza vaccination program, we actually do have a quite good uptake. It's we have a free of charge program for all vaccines that's within programs. They are all voluntary, and since the COVID pandemic, we've actually seen quite an increase in the uptake both of the influenza programs and also other adult programs. So right now it's we have a coverage among this plus 65, that's 76%, and when we look at the older population, it's up to 85. And as a new thing this year, we actually used an advanced influenza vaccine. We used the adjuvated. And we just made some interim vaccine effectiveness studies, and we could actually show that it was a benefit for us to look at the adjuvated influenza vaccine, since it had an effectiveness of 48%, and as compared to 33% for the standard vaccine. And we published that in the Eurosurveillance, I think it was last week. We are aware that even though we have a quite high coverage on the programs that we do have some pitfalls, and we do look at that every year, and especially the ones who are under the age of 65 but at risk due to comorbidity, which I think the next speaker, Dr. Vale Olivier, will go into. They actually have a low risk perception, and we do have a quite low uptake in those groups. And then, and also looking at specific the groups that are younger than 65 and have comorbidity, we also do have less of a provider recommendation, or at least it's not so clear. And then, of course, there can be logistical barriers, and that especially is true to the people who find it hard to for instance, get into vaccine clinics, which can be further away from their natural, for their homes or other places, which of course can mean something for the most vulnerable. And the next one, Ella. And then, of course, our child or infant immunization program is quite strong, and that also might point to that having this continuous long-standing vaccination program does prove to strengthen the uptake. And when we look at the childhood vaccination coverage, which again is free of charge and also voluntary for the DTaP IPV HIP and program, is 94%, and the MMR, it's also 93 and 91, still lacking a bit of a percentage towards the 95% goal. And again, we look into where we have the pitfalls for the ones not underserved or unvaccinated. And again, we see there is a disparity or discrepancy barrier, and we do see that it's that it has is particularly among social or geographically less fortunate children or families. We do have some misinformation, but We have seen that particularly among our HPV programs going some years back, where we had what we call an HPV vaccination crisis. And it just gets to show that even when you have a very high vaccination coverage, you have to be on your toes, and you have to be agile towards new misinformation, which of course is also important for the ones that are actually have a high coverage now. Next one, Ella. So just to touch upon that vaccine hesitancy, it has been put into WHO top 10 global health threats. And as just said, we have seen it in Denmark, primarily on the HPV vaccination program, which I have to say is back on track. And we do have a high coverage now, but it was devastated. I think it was 2016 to 2019, where we did see a drop to below, I think we were around 30%, and we came from a vaccination coverage of 80. And now we are back, and this was a long and multi-dimensional effort. And what we actually did was actually to build trust in our communication on the providers who did the vaccination, and gave them the scientific arguments and also the skills, and of course also to actually be able to respond to whatever needs was out there. And we did a lot of communication on a lot of different platforms. So and I think it's safe to say that this was a great success, and we are hoping that some of the same tools can actually be used in a further crisis. Next one, Ella. So from our point of view, we would appreciate, and also hearing from colleagues around the world, how to integrate a vaccination program that is through the course of life, and how is that, do the focus on the needs of the ones who might be underserved, but still may be the ones that are most in need. How do we reassure that? And then again, like we did with the vaccine and the misinformation, actually this cross-sector collaboration is extremely important. At our side, at the National Board of Health and the State STEM Institute cannot do, and the governmental side cannot do a good job without the providers and the outreach and the communities. I think that was it, Ella. You say yes, and I just say thank you for, and looking forward to taking your questions in the end.
Great. Thank you so much for that presentation. Next, I'd like to introduce our next speaker, Dr. Catherine Vieux-Olivier. She is a member of the leadership team of the Coalition for Life Course Immunization, and she will be speaking on vaccination strategies across the life course, specifically focusing in older adult populations. So.
Yeah, thank you all for the invitation. You may be surprised that as a pediatrician, I am being concerned by vaccination at all ages, but please remember that we are in a center of a family when we take care of a kid, and we need to focus on infectious disease at any ages. And second, I have been in the vaccine field for more than 30 years, in the registration for over 15 years, and then strategies in my country for 5 years. And I'm still in InfoVac France since the beginning of the 20th century. So I have maintained a large experience. So who are we taking off? Any age from 18 years of age, including pregnant women, travelers, high-risk group.
I think Dr. Weil Oliver has frozen.
For me too.
Yeah, I'm not hearing her either. Dr. Wyatt, Olivier, you've frozen.
Yes.
Okay. We'll give her 1 minute and see if she's able to regain the connection. And if not, then we can reshuffle the order a bit.
I hope it was not a virus in her computer.
It's a shame we can't vaccinate. Oh, actually, we can.
Okay, well, while we're waiting for her to reconnect, we could move on to Dr. Tan, if you're okay with that.
Yeah, absolutely. I'm okay with that. The only challenge with that's going to be the fact that I was, my slides follow naturally from her a little bit better, but that's okay. We'll figure it out. All right. I'm going to share my screen. Okay. Hopefully you can see my screen now. And I just need confirmation. Am I in slide mode?
No, it's in the PowerPoint interface.
Okay, let me see. Let me figure this out. Then I need to come back here. It worked earlier. Now, for some reason, it's not letting me do it. Okay. Now it should work. Please say it is. Perfect. Okay. Hello, everybody. I'm just going to jump in. My presentation would have followed nicely off the previous presentation, but I'm just going to go ahead and get started. I'm the Chief Policy and Partnerships Officer for Immunize.org, and I also co-chair the National Adult and Influenza Immunization Summit in the United States, and I also co-chair the Global Influenza Initiative. That's a global flu initiative that I co-chair with Bruno Lina out of Lyon. And I have, just for some experience, I have served on the Advisory Committee on Immunization Practices at the ACIP in the United States, and I've also served on the National Vaccine Advisory Committee in the United States. So I was going to just kind of follow up, and Dr. Wal Olivier was going to talk a little bit about some of the barriers to immunizations. And I think what follows naturally from barriers from immunizations are what works to try to overcome some of those barriers. And in the United States, while this is a United States specific barrier presentation, I want to also point out that a lot of what we talk about in the US is also very globally relevant. So I think you can see how some of these things will actually will be able to be part of the process in terms of helping you overcome some of the barriers that you hopefully will get to hear about in a few minutes. So firstly, the barriers are broken up into 4 different categories, the way I've done it here. The first one is the one that probably has the most success, and that is what we call health system strategies. These are strategies that take over the entire hospital, an entire clinic, an entire system, right? So you make this change the top level and it filters down to everybody, and therefore everyone just benefits and improves. And so under this strategy to improve, to overcome barriers and improve immunization rates are things like improving your registries, your information systems, what captures your data systems, in other words, who gets what vaccines, improving understanding and awareness of all the adult vaccine recommendations that are there among all the professionals in your system. So doing a lot of educational programs to make sure everybody, not just vaccinators, but also all your administrative staff are aware, because you don't want administrative staff undermining your clinicians, So that's one of the things you want to make sure that your receptionist also says, oh yeah, vaccinations are very important, instead of saying something like, oh, why are you getting that vaccine, right? So those things are things that you want to make sure. You want to link performance to vaccination. That means, if possible, incentivize. If you perform at this level, we'll give you a bonus of some sort, maybe a pizza party. I don't know, something like that. Leverage technology. Obviously, this is the idea of making sure the data gets shared. So if pharmacists are vaccinating in the United States, they get access to the same immunization registries as the doctors, so that if you gave a vaccine at the pharmacy, the doctors immediately also know that they've got the vaccine. So that technology gets unified, right? And then finally, combination vaccines is another great way. If healthcare systems implements combination vaccines, you can go ahead and make sure that everybody gets that vaccine, reduces the number of vaccinations necessary, makes it better for your patients. The next bucket of strategies are directed at the healthcare professional. And I have to say, the second bullet here is probably the most important bullet. And I know that was going to be one of the things that we talk about today as well, is the importance of the healthcare professional endorsement. So all of you as healthcare professionals, when you tell a patient, a member of the public, that it is incredibly important that they get vaccinated, they will likely listen to you because you are that healthcare professional. You are the trusted physician, the trusted nurse, the trusted medical assistant, pharmacist that they trust, right? But on that level, we also therefore need to make it easier for healthcare professionals to recommend the vaccines. In the United States in particular, and I'll show you a quick slide on that later, there's so many vaccines that we have to give that we need to make sure vaccine recommendations are simplified. We need to make sure our specialists are also talking vaccines. In the US, a lot of our cardiologists, our endocrinologists, all the people who are working with high-risk populations don't tell their high-risk populations that they need to get vaccines. And so what we're trying to do is make sure that these specialists are also talking vaccines. And we need to address disparities with our professional strategies. And you're going to hear a wonderful presentation on community outreach and how that can help get vaccines into places where you don't typically can get vaccinated. So I think that's a wonderful following presentation. And then finally, of course, we want to expand any kind of clinical support that you can give to people who are vaccinating. The third bucket, patient strategies. Now, this is the hesitancy component, right? So we got to make sure that our patients also understand the concerns that they are feeling with regards to vaccination, especially after COVID, because COVID, especially in the United States, was very polarizing. So that means you got to customize your message. It's not one size fits all. It doesn't work. You got to look at your patient and you got to listen to your patient and then understand your patient concern and change your messaging so that it meets the patient's needs, right? So you cannot just ignore what the patient's telling you. You got to listen and you got to then understand and then you respond. You got to vaccinate people where they are. Where do they live? This is the community outreach again. And then we need to start thinking like the big commercial companies. How do we market immunizations as something that's cost savings, cost effective, prevents deaths, saves hospitalizations, prevents sickness, prevents illness? All wonderful things. We just have to market it better, right? And then finally, again, the community outreach, which you will hear shortly about. And finally, at the policy level, which is obviously something IDA is very interested in, how do we change public policy in a country, in a region, in the world, so that we can get everybody vaccinated, right? So that means eliminating the financial barriers to vaccination. And you've already heard Dr. Seabrook say, if you don't pay for something, it's kind of hard to get people to vaccinate. So having a socialized system where vaccination is covered is one way to do that. And then if you don't have that, for example, in the United States, you got to continue to advocate to make sure that funding for vaccines continues to exist. And as you can all be aware of, we are definitely in that battle in the United States right now. So I'm going to talk very specifically now about one of the things we're doing in the United States that I think might be relevant throughout the world as well. And that is, how do you operationalize all your adult vaccines throughout the year, right? In the past, adult vaccines used to be something like, oh, it's the fall. It's time for flu vaccine. Okay, I've got flu vaccine. All right, I'm going to give my patient the flu vaccine. What else can I give at the same time? So we're saying you can't do that anymore. You need to think about how do you give vaccines throughout the year, recognizing that in the fall, when there is flu season or RSV season, you now have vaccines that you have to focus on at that time and point. So one of our goals right now is try to educate our providers that you need to give and think about vaccines throughout the year. And this is the reason why. In the United States, we have 9 routinely recommended vaccines for adults: COVID, Hep B, HPV, influenza, MMR, pneumococcal, RSV, Tdap or TD, and zoster. So all these vaccines, 9 of them are routinely recommended for adults. So if you think about what I just said and you say, oh, I'm just going to do it during flu season, you're going to have a heck of a time trying to get 9 vaccines into people, right? Not saying that they all come at the same time, but the idea here is you need to think about how we spread these out over the course of a year so that many people can access all these vaccines. And that's what we call this idea of operationalizing adult vaccines through the year. And so one of the ways you do this is think about how you can assess and offer vaccines through the year. So if a patient comes in non-flu season, think about hepatitis B, think about Tdap, think about MMR, think about HPV. Are the patients recommended for those vaccines? And if they are, assess and offer outside the flu season or the RSV season. And then during the RSV and flu season, since they're seasonal and COVID-19 as well, think about how you can align all of those so that you can give them at the same time. And what this means is co-administration. If a patient comes in one time and that may be the only time you see that adult patient, try to get these vaccines in all at the same time: COVID, flu, and maybe RSV if the RSV vaccine has not been received by the patient at that time and point. And then finally, making sure that you can communicate across multiple access sites. I mentioned this earlier by using information technology, right? So that a patient can get vaccinated at many different places, but you know that the patient has received all those vaccines. And then some tools that we have created at the summit to help kind of put this into place is what you see here. So the one I'm going to really talk about is, as you can see on the bottom left, we have the fall respiratory viral season, where we try to help our providers understand how they can give these vaccines appropriately during the flu season, the COVID season, the RSV season, and then think about how to give other vaccines throughout the year. And that's on the top right, where we have a 1-year vaccination action plan, right? In this plan, the provider can check off the vaccines that they recommend to the patient, and then they can use the calendar and put in on the calendar, as you can see, the different vaccines that you can give outside flu season. So as you can see here, you can see on this one in January, there's a second Hep B vaccine. Because the person came in September for flu vaccine, you make the flu vaccine plan, and then you give COVID, you give flu, and then in December, you give your first Hep B, and then and so on and so forth. You can see that what I'm getting at here is how do you spread out these vaccines so that the person can get all these vaccines that they need, but not all crushed into that flu season time. And then finally, just a note, we've just recently published a publication where we reviewed the literature on co-administration. The big picture is for all these different combinations, co-administration is safe. I have the link at the bottom. I encourage you to take a look at it. And then at immunize.org, we even have a document to show you how you can give 2 or more vaccines in the one deltoid muscle so that you can co-administer safely and effectively. And then finally, I want to come back to this. Your personal professional recommendation is so important, especially right now in this time of vaccine hesitance. So you have to not only get vaccinated yourself so that you're a good role model, but you're also telling your patients that they get vaccinated. So whether you're a specialist or a primary care provider, you should be talking and recommending vaccinations to your patients. Here are some resources. If you want to get continual updates to immunization immunization news at the very bottom, please subscribe to our publications. You will get a lot of great immunization relevant updates. And I'm going to pause here and thank all of you for all of this. And this is in hoping that our any kind of avian flu is not going to spread. So thank you all very much. And I'm going to turn it back to you.
Great. Thank you so much, Dr. Tan. All right, and then we can go ahead and move on to our next speaker, who is Isang Sendra, and she is the executive director at GUFARM, a youth-led health nonprofit based out of Cameroon, and she will be speaking on community outreach and vaccination programs within a life course approach. So over to you.
Good afternoon, everyone. I'm called Isang Sandra, the Executive Director of GoFem based in Cameroon. I'm a nurse and epidemiologist by profession with some experience in health advocacy and humanitarian activities. It's a pleasure to be here today. I thank the IDA for this great webinar and this opportunity to present here today. We'll just dive in. Vaccination is one of the most important, powerful tools in global health. It saves lives, prevents diseases, and strengthens our communities. However, despite these benefits, millions of people around the world still lack access to vaccines due to various challenges, such as misinformation, logistical barriers, and policy gaps. Today, I'll walk you through effective community outreach strategies and solutions that can help bridge this gap and improve global vaccination coverage. And by working together, government, civil society organizations, healthcare professionals, and the community, we can make vaccine accessible to everyone and create a healthier future for all. Some of the community outreach programs that we can engage in to improve the vaccination coverage globally include: we can do the mobile and pop-up vaccination clinics, where especially in rural and hard-to-reach areas, we do door-to-door vaccination. We can also bring vaccines to where people gather, in markets and in schools. We can also offer vaccines along with general health checkups during our mobile health units. Another program we can do is community engagement programs, where we train and empower religious leaders, teachers, and respected community figures to advocate for these vaccines. We can also deploy trained healthcare workers to educate and vaccinate people in underserved areas. We can also organize forums where parents can discuss consent and learn about the vaccine's benefit. Another program we can do is the public awareness campaign, where we use the social media to engage content and also use the radio and TV to send SMSs, especially in areas with limited internet access. We can also use the billboards and the posters to pass simple, clear messages in local languages. Another outreach program is the incentive and support program, where we offer small incentive for getting vaccinated. We also combine this vaccination effort with food and supply distribution. You know, there are some humanitarian organizations that deal with food and supply distribution. So we can combine this vaccination effort with this aid program. We can also provide vaccination certificates for adults and children who go to school and for work purposes. Another outreach program is for partnership and with NGOs and businesses. We can partner with companies to vaccinate their employees, work with humanitarian organizations to reach the marginalized group. Though we have all these community outreach programs, we still face challenges in achieving this vaccination coverage. We have vaccine hesitancies and misinformation, where we have misinformation, cultural beliefs, and distrust in the healthcare system, which contribute to this vaccine hesitancy. And tailoring our communication to address community-specific concern is crucial for both infants and adults. We also have limited access to healthcare. We know in many low and medium income countries, insufficient healthcare infrastructure, cold chain maintenance issues, and limited access to healthcare facilities can hinder both the infant and adult immunization effort. We also have financial and logistical constraints, political and policy challenges. Cost, limited healthcare budgets, and competing health priorities may lead to underinvestment in vaccination programs. We also have epidemiological shifts. The emergence of the new pathogens, such as the SARS-CoV-2, and changing epidemiological patterns necessitate adaptation in immunization strategies across all ages. Despite these challenges, there are also strategies that we can put in place to this vaccination coverage. We can strengthen the healthcare system and infrastructure. We combine the routine immunization, infant immunization, with adult vaccination services at community health centers, which can help to improve access. For example, leveraging the maternal and child health visits to also educate parents about adult immunizations for themselves and other family members that can help to create a holistic approach. We can also enhance the cold chain logistic and distribution systems, ensuring that vaccines are stored and transported safely, reducing wastage and ensuring efficacy. Another strategy is policy and financial initiative. The policies that prioritize vaccination funding, both for infants and adult immunizations, are very critical. This creating national immunization strategies are very adaptable and will help to adapt to new vaccines development. And we can also implement mandatory vaccination policies for school entry and certain professions to improve vaccine compliance. We can also collaborate with private sectors and international agencies such as the WHO and the Vaccine Alliance that can help mobilize resources and expertise to expand this coverage. Expanding coverage through government subsidies and insurance mandates can reduce out-of-pocket payments for vaccines, especially for the adult population who might not be covered by the routine childhood immunization program. Another strategy we can use is community engagement and education. Here, we target community communication campaigns. Cultural sensitive education initiative can help address misconception, distrust, and fears about vaccination. Involving community leaders and healthcare providers in this dialogue will help build trust and encourage vaccine acceptance. We can also use the mobile health application apps and digital registries to remind patients of upcoming vaccinations and track immunization status across population, ensuring better follow-up. Another strategy is in the innovation in vaccines development and delivery. With the next generation vaccines, we can research into vaccines that offer broader protection and require fewer doses or are easier to administer, such as the needle-free delivery system that can help overcome some of the barriers such as fear, costs, and logistics. We can also adapt the immunization schedules to local epidemiological data and healthcare capabilities, ensuring that both infants and adults receive timely and appropriate vaccines. Another strategy is the equity-driven initiative. Programs like the Immunization Agenda, the IA 2030, it's a very good strategy because it aims to ensure that vaccine reach underserved populations, emphasizing on equity and accessibility. Below are some examples of successful community vaccination programs and strategy. We have the Global Polio Eradication Initiative. This initiative has not only reduced polio incidents drastically, but has also strengthened overall immunization systems, providing lessons for both infant and adult immunization strategies. We have the COVID-19 vaccination campaigns. The rapid global rollout of COVID-19 vaccines has highlighted that the importance of flexible, scalable immunization infrastructure and the need for clear communication strategies to counter misinformation and hesitancy. We also have the expanded program on immunization that was launched by the WHO and which has been very instrumental in raising infant immunization rates worldwide and can serve as a model for integrating adult vaccination program. Though challenges still exist, vaccination is essential as it prevents diseases, strengthening global health. By addressing both infant and adult immunization needs and implementing comprehensive strategies, we can enhance vaccination coverage worldwide, reduce the burden of infectious diseases, and improve overall public health outcome. By combining local engagement, innovative delivery method, and strong partnership with the government, healthcare professionals, and the communities, this global vaccination coverage can be achieved by higher immunization rates and a healthier population. Together, the government, healthcare professionals, civil society organizations, and the community must collaborate to ensure that vaccines remain accessible, acceptable, and effectively administered to all. Collaboration is the key. Thank you.
Great, thank you so much for that presentation. It was really great. It looks like Dr. Vieux-Olivier has rejoined. And if you would like to share your slides now, that would be wonderful if you have a solid connection.
Sorry, where was I stopped? Did I have a start?
I think it was pretty much at the very beginning.
Okay. Do you want to finish with the speakers and I will be the last?
You are the last. We're set to
okay.
presentation now, if that's all right.
Okay. So I start again.
Yeah.
And I will stop my camera.
Okay, that's all right. Would you like me to share your slides or would you like to share them?
No, I have the slides. So just tell me if it's okay for you.
Okay, we can't see them yet, but let me know.
You see them?
No, we cannot.
So do you see them?
No.
Okay. So I think the simplest is that you have the slides and you show them.
Yeah.
And I will say next.
Absolutely.
Okay.
Perfect.
I'm sorry for that.
Okay.
And I won't put my camera.
That's
Good.
right.
Can you enlarge them, please?
Yes. How's that?
Good. Thank you. So starting again, I am a pediatrician basically, but I worked in the vaccine field for 30 years now and over, in the registration first for over 15 years and then strategies for 5 years in the French NITAG, but also on very practical issues through AfroVac France. Next. You may be surprised that I am interested in adults and older adults, but as a pediatrician, obviously we need to take care of the family and not only the kid per se. So we are working on pregnancy, travelers, high-risk groups, and older adults in order to protect the whole community. Next. As you may see, and you know well those data, the population 65 and over is increasing, and it will reach over a quarter of our population by 2050. So we have to take in consideration that increasing with age, immunosenescence and comorbidities are major factors. Next. The number of comorbidities increase with ages, and here I focus on 3 comorbidities, and you see the increase by age groups. Next. On the same kind of perspective, if we consider vascular mortality, it's increased by infections, and the same for cancer mortality, as you may see on those slides. Next. So if we determine those adults and older adults, definitely with aging, vaccine preventable morbidity becomes more prevalent. There is more susceptibility, increased exposure to infectious disease, whatever the activities. And we need to be more focused on catch-up immunization, regular boosters, and also new indication with this 65 and over population, but also new vaccine or administration routes. Next. So my conclusion intermediate for immunization in older adults, that there is a greater incidence and or severity. Chronic diseases are more numerous, immunosenescence, and due to the change of the immune system, more chronic inflammation that reduce probably effectiveness to some vaccines, but increase the risk of infectious disease also. So these are the main targets. And in parallel, you have the uptake in 2022, showing that first, during the early beginning of the pandemic, primal vaccination was well done, but much less for influenza and even less for pneumococci. And as you may see as a regular routine, we have very poor implementation of vaccine zoster uptake. Next. So my take-home message that first, we have nothing to retire to a childhood program. It has to be strong, efficient, and improved. But at the same time, vaccination should be a continuum. And the message for the public is at any time of your life, a vaccine may protect you. And it has to be understood that we have implemented adolescent vaccine, and we have to explain to them, because they will be adults, and if they are accustomed to receive vaccine by adolescents, they will go on further on with adults and elderly, and they can convince their family to get vaccines. Now, as population through adulthood and elderly, you have obviously pregnant women, and we have real programs. We have high-risk groups, travelers, healthcare professionals, and later on, nursing homes. Next. So what has been done? For adults, older adults, we have a French calendar, and we have very recently implemented pneumococci with PCV20 for all adults, routinely, and only one dose. We have also implemented and reimbursed zoster vaccine in adults 65 and over, and there is a large demand for this vaccine. Next. So where are the caveats? Next. We have several lines of vaccine recommendation. Those are recommended and reimbursed, most in the calendar. But we have also recommended but not reimbursed. Those are the travelers vaccine. And we have, last but not least, the not recommended routinely. And for example, meningococcal ACWY is now for adolescents, but not yet for adults and older adults mainly. Next. Just an example of the very poor uptake of vaccination against pneumococci in 2022, explaining why we have introduced finally a single dose of a very efficient vaccine, PCV20, for all 65 and over, including, obviously, comorbidities. Next. The heterogeneity of our schedules is something that is an issue, and I have focused mainly on pneumococci. This is France, and you see that no recommendation, only risk groups recommendation or routine recommendation vary country by country, and this may be very difficult to understand for adults and healthcare professionals. Next. Another example is seasonal flu vaccine in adults 65. WHO objective is 75%. France is here, but most of the countries don't achieve the 75%, and this year after year. Next. So what has been done to improve? And I will give you some examples of vaccine uptake very rapidly. Next. So for example, we have started working more on vaccine uptake in French adolescents. And you see here, starting with MenC vaccine uptake, that it was good after the mandatory in this population under 2 years of age. So we have achieved our objectives. We are still increasing the adolescent vaccines uptake. It's not exactly what we should want, and we have substituted now MenC by ACWY, expecting a good uptake. And on the other side, you have HPV vaccine. We are improving at least one dose or 2 doses schedule, both in girls and boys. Honestly, I consider it's not still enough. Please, next. See, if we focus on adolescent HPV vaccine, we have introduced this French school program. It's not yet perfect. It's for 12 years of age, girls and boys, introduced in September 2023, still going on this year. And we are on the way to evaluate the benefit of this campaign, but we have increased the coverage rate, not as much as we expected, but yet we are on the way. And we would like really to enlarge the school program with MenC AWY. Why? Next. For adults, the health authorities take now in consideration the perspective of the public, and they want to know better about the reluctance to certain vaccination. But if you compare those years to the last years, we have, it seems to be, a better acceptance of influenza seasonal vaccine, Hep B vaccine, HPV vaccine, much less for COVID vaccine. So it seems that the potential of hesitancy and reluctance to vaccine is decreasing in adults and older adults. Next. Yet, we have a lot of information now for healthcare professionals a lot of leaflets and internet. For the public, we have several leaflets also. And my surprise was with these keywords, vaccination adulte, on the front page, it appeared clearly that it was no more anti-vaccines groups, but the French authority groups. So this is a good point. Next. Opening vaccination competence to all healthcare professionals, including pharmacists, nurses, midwives, is extremely important. Pharmacists are allowed to vaccinate from 11 years of age now on, and they may prescribe vaccine. And I think within the French calendar, but it's a huge progress because it's much easier and we improve vaccine uptake of the population. Next. So what are the barriers and challenges? Next. First, to take in consideration the patient side, I won't detail that because everyone knows about what they are thinking, what they are fearing. On the healthcare professional side, we absolutely need to communicate, inform, understand, and there are still a lot of unknowns because they don't know all the risk of infectious disease. I could give you with time some examples. Previous vaccination status is not well known, and what is needed and recommended and varying year by year. So definitely we need more data. Next. Several kind of barriers. We need to enforce our epidemiology and surveillance strategies, but so far they are quite good in the country. How data are utilized for the decision-making process, and try to focus more on the benefit for adults and health security and economically driven, and then the recommendation. There may be an issue of vaccine market access, but the major issues are the vaccine uptake, and that is multifactorial, so we have to work on that. And clearly having divergent vaccination policies definitely risk fueling mistrust and hesitancy. Next. Healthcare workers play a major role, as I said, so they are driving broader health system benefits, but there are several bottlenecks, as you may see. Lack awareness of recommendations is very surprising, but it's true. Verticalization of immunization, limited capacity, resources, and staffing, and limited data on the coverage. We need feedbacks for them. Next. So the main objective is definitely to increase uptake of vaccines. So we have to work more on trust, confidence loss, reluctance, hesitancy, and maybe being as transparent as we can be, having championship for disease and their prevention, and community outreach could help. Next. I'm nearly finished. These are the summary of challenges. They are common through Europe. The main point is how can we focus more and more efficiently on adult immunization and life course immunization. Next. How to succeed. I won't detail any of the boxes. There are several boxes, several perspectives, and the fact is that they are complementary. If we drop a box, we are losing something. So we have really to work at the same time in different directions. And I may say that we need probably to adapt our messages to each of those boxes. Next. And this is my last message for adult vaccination. We need to focus more on vaccine uptake and give a feedback of our uptakes, having the strong data, better vaccines, political and health authority support. It appears that when we have a real support, it works much better. Budget availability, which may be really an issue, specific research funding, and more work with the public. And I finish with that because the public has been forgotten for a very long time. And the last, please. And you have here the summary of all what I said and the necessities we have to think of when we want to implement a life course immunization. Thank you.
Great. Thank you so much for that presentation, Dr. Violivier. And thank you to all of our speakers for your presentations and for your flexibility. Now I will move on to our Q&A session. We do slides. I think we have about 10 minutes left. So let me share this. And so if you have any questions at the moment, feel free to either raise your hand with that function or to type it in the chat, whatever you're comfortable with, and we would love to hear them.
So perhaps I can get the ball rolling.
Perfect.
And I sort of picked up a few. First of all, congratulations to all our speakers for their excellent and comprehensive presentations. You've raised so many issues and identified some hot buttons. But I'm going to pick on one or two of you, if you don't mind, to expand a little bit. Dr. Suborg, you've outlined some, of the things that you're doing in Denmark. If you could pick one of those. And think, is this something that we could really be implemented across Europe, or indeed in a global context? Something that's worked, or you think is working in Denmark, that has kind of global applicability? What would that be?
I think that our efforts to actually combat our HPV vaccination crisis has been an effort that I definitely think could be a contribution to other countries. And I know that we have actually helped France. I've been to France to actually help to draw out a similar kind of plan for combating low coverage.
Yeah, well, I think that's a great example, and it would be great if we could think about, how you can do that in a really active way rather than a sort of ad hoc way, because I'm sure there are lessons there for other countries. There's nothing like real life experience, I think, for this sort of thing. Are there any questions pending? Ella, I'm not seeing any. Otherwise, I'm going to ask Dr. Tan now something. So thank you so much for your presentation. One of the things that you came across loud and clear is the importance of healthcare endorsement. If your doctor or your nurse or pharmacist or whatever tells you something is a good idea, you're more likely to do it. How do we get that to be a priority? I mean, I'll fess up. I had my shingles vaccine this year, but nobody asked me or told me to do that, despite, the fact that I see my doctor and pharmacist all the time. So how do we get that something to be, more important kind of in the physician's mind, so that they can make that step to recommend it?
So that's a great question, Norman, and I think, please call me LJ. I think one of the things I want to point out with that is that it's push and pull, right? The provider, the physician, the clinician, the nurse, whoever that healthcare professional is, has to be educated on all the benefits of immunization, so that they themselves believe that it's important. That's the fundamental starting point. So education of the provider, because if you as a healthcare provider, I always used to say, when I talk to, my providers, a obese physician is never going to talk about weight management, right? A physician that smokes is never going to talk about smoking cessation. So if you don't believe in immunizations yourself, you're not going to talk about it. So that's the first starting point. But once that is done and you have clinicians that believe it, then you can put on top of that systems change, right? You can make systems in hospital level, you can make it at the clinic level, such that now you make it very easy for the physician to just give the vaccines. So you can do things like, for example, you can do reminder recall, so that the physician can say, hey, you've got a patient with diabetes, talk to them about flu and pneumococcal vaccination, right? So now that the physician believes, they can now talk, right? So that's one way of doing that. Other ways, for example, is standing orders. You just essentially say, if everyone believes in vaccination, you make it such that the patient comes in and you offer the vaccine, whether by a nurse, by a pharmacist, by a provider, without any further conversation, right? So that's what we use in the US a lot in our hospitals for what we call standing orders. And those standing orders can be done at discharge. They can be done at the emergency rooms. They can be done on entry as well. ERs are a little bit harder, but we can try for those as well. So multiple systems, right? First, it starts with the doctor, the clinician believing, and then you put systems-based change on top of that. I hope that makes sense.
Sure. No, it's that belief that's the first step.
Yes.
So thank you for that. I mean, Dr. Isong, I really enjoyed your presentation, and I must admit I hadn't heard of GooFerm before this webinar, but I looked up a little bit and I see some of the great work you're doing, on disadvantaged populations. Now, I want to focus on one group, and that's pregnant women. And the reason I want to ask that question is because they are an increasingly important, audience. Let's say in terms of vaccine, there are more and more vaccines that are recommended in pregnancy, either to protect the pregnant woman or their unborn baby. Is there anything you can share from your work that has improved access or uptake of vaccination in pregnant women specifically? And you're on mute, by the way, Dr. Isong. So if you could unmute yourself, that would be great. You're still on mute. Hi. Okay, you're off mute now. Oh, no, you're on. Right, we can hear you now. Yes, pregnant women, really important group, increasingly important. We've got CMV vaccines coming down the road. Vaccination in pregnant women is going to become an increasingly important issue. I know you've done a lot of work on that. On that, would you like to share some of the things what you've done to improve access and uptake for vaccines in pregnancy?
Currently, we are working on the universal health coverage. We have a scheme called the Check Santé here in Cameroon, where we encourage pregnant women. They pay a particular sum of money, then they have services that are being rendered for them free of charge. So when those women that are under that scheme, we go to the health centers and the communities, we encourage them. There are some vaccinations, like we have the ATT given to pregnant women. We encourage them to take them, and during their ANC visits for women, because not all pregnant women take all the vaccinations. Some of them, due to monetary issues, they take just few. So we just advocate, we encourage them, especially during the universal health coverage programs. We always encourage them during these visits to take these vaccines, and we do follow up to ensure that when they take the first dose, they continue with the second doses and the rest.
Thank you. Thank you. And Ella, thank you for that. And because I want to give each speaker a question. So very briefly, Dr. Catherine Val-Olivier, something you said, it was kind of a throwaway remark in your presentation about hesitancy going down in adults. And I get the impression that it's going up in children, maybe not in France, but how do you explain that? Certainly on a global scale, hesitancy is an increasing problem, and particularly impacting children, but it's going down in adults. Is that a blip, a post-COVID blip, or how do you explain that? Is there something we can draw out of that?
First, if we focus on COVID vaccines, I thank you for your point, because it seems a bit paradoxical. They are not well taken this season, COVID vaccines. I would say that 80 plus were 30% uptake, 65 plus were less than 15%, but it's not specific of France, it's all countries. On the contrary, knowing that influenza is a very strong epidemic, or that we have extremely important meningococcal epidemics at the time, then we see people interested. And one of the fact is that when people hear about epidemics, the fear of the disease is much higher than the fear of the vaccine. And so unfortunately, it's a way to make them vaccinate. For example, this summer you were speaking about pregnant women, and we had a very strong pertussis epidemics, as many other countries. And then all the pregnant women decided that they could be vaccinated, and the uptake was up to 80 to 90%. So I don't know if it will stay that way for the next years, but so far, the fact that there is infectious disease and we communicate about the risk of infectious disease is a driver.
Yeah,
For children, it's something totally different. Young kids under 18 months of age have a mandatory vaccine. It's followed because it's simplified the way for healthcare professionals. And I do share the perception of Professor Tan that if healthcare professionals are convinced that their life is easier with mandatory vaccine, they don't have to argue, they don't have to discuss anymore. And so the uptakes are up to our objectives, 95% for all the vaccines, mandatory. Then it starts being a bit more difficult, but the difficulty is more at adolescents, because adolescents vaccines probably, we do not succeed exactly to catch them, to interest them. We are improving in this sense. We are creating videos more adapted with the language of adolescents in order to convince that it is interesting to get vaccinated. Yeah. For example, it's not only adolescents, it's also young adults. They are in different schools, third grade school after college, and they know there are epidemics. And once again, they prefer to get vaccinated and follow on their course. So it all depends on the context.
Indeed. So very clear, different messaging strategies depending on the population.
I think it's extremely important.
That's very insightful. Ella, I think we're probably about out of time now.
Yeah, perfect. Thank you so much for those questions, Norman. Those were great. And thank you to all of our speakers for participating today. I've got a few brief closing remarks. And I want to share our call to action on the ID website. I believe it's already in the chat, but I'm going to add it one more time. Anyone who is interested, please, we encourage you to read and sign our call of action. And yeah, as the IDA, we want to advocate for increased funding and policy action to prioritize vaccine-preventable diseases at national and international scales. We want to engage with communities and support local solutions to ensure sustainable disease elimination efforts. And lastly, we encourage you to stay informed and collaborate with us, share today's insights with your networks, and explore ways to contribute to the fight against VPDs with us. Following this webinar, I will share an event report summarizing what we talked about today and the video recording so you can have to share with your network if you would like. And yes, I just want to thank everyone for your time today and your flexibility and your dedication to global health. And we look forward to continued collaboration and progress in the future. Thank you so much, everyone.
Thank you, Ella.
Thank you for the opportunity.
Thank you, Ella.
Cheers, everyone.
Bye-bye.
Thank you.
Thank you so much.